Here we are, Real Recovery Talk. I am your host, Tom Conrad. In today's episode, we've got Benjamin B.
What's happening, everyone?
And we also have Dr. T.
Hey.
I call her T.
Is that recording?
Yeah.
Why'd you do that to me?
Do what?
Like my OCD, now I can't see that the little red thing's going.
I don't know. You're just going to have to live with it. First things first. Thank you for tuning in on the podcast app, whichever one that you choose to use. And thank you for watching on YouTube. In the end, if you have any comments, questions, or concerns, you could always reach us, info@realrecoverytalk.com. Again, it's info@realrecoverytalk.com. And ultimately, we want to help you turn your mess into your message. Right, Ben?
Yes, Tom, that is what we are here to do.
All right. Right, T?
Right.
You like that?
Okay,
Committed.
So the previous episode, one of them, I don't know when this one's going to go out, but we were covering alcohol detox, and we're going to stay on that trajectory. But this time we're going to be talking about what I believe is to be the best form of detox when it comes to alcohol. And again, we are talking strictly alcohol. So we're not talking about opioids or anything else other than alcohol. But I guess, we can classify benzos into this as well. Mm-hmm. Alcohol and benzodiazepines. So your Xanax, your Ativans, your Valiums, your Klonopins, your, what else? That about covers it.
Common ones, yes.
Yeah. So if you, like to dabble in, some Xanny bars here and there, this episode could be for you too. If you're, taking a lot of Xanax, then
French fries.
Is that what they were called?
Yeah, the bars.
Yeah.
Here's a question.
French fries.
Just out of curiosity, like, why does there need to be a 2 milligram Xanax? Like, that is so powerful.
Yeah.
Never had one. I don't know.
Oh, really?
No.
Yeah.
The sticks.
Yeah.
And
The bars.
They would
bars.
you can break them into segments.
That's too much work for me.
Yeah,
I break
I
it
know.
up and just eat the whole thing.
All right. That's what I say.
I seriously have always wondered that though, like why such a high dose?
It's like a Hershey bar. You ever notice a Hershey bar? How they're etched to where you could break off pieces,
Like
and
who
it's
would
like
even eat just that one little sliver of a Hershey's
yeah,
bar?
yeah. I don't get it.
Just break it into the thirds or whatever it
Yep.
is.
Yeah. So Pfizer or whatever one of you people make those. I don't know. Maybe discontinue the 2 milligrams and, I've never met somebody that is prescribed 2 milligrams at a time, like,
Oh no, I've met them.
no, like 2 milligrams at one time.
Yeah.
Because normally it's like, okay, doc. How would you prescribe Xanax?
I would start at the lowest dose. So I would start
Which
at
is-
like 0.25
Right, that's what I'm
milligrams
saying.
or 0.5 milligrams.
I've never met anybody that was prescribed that, trust me, I know a ton of people that would take that much and a lot more, but actual prescribed. But anyways,
Maybe it's not a big thing anymore. But I'm referring to back in the doctor shopping days when all the Oxycontin stuff was going on. Like,
well, now you can get, they have the pressed ones that are,
They're lookalikes, but they don't always contain Xanax.
yeah, it's fentanyl. Mm-hmm. So that's a topic for another day. This is strictly about detox. So again, alcohol and benzodiazepines, we just threw that in there because it's all one and the same. So we covered in the previous episode, you can go back and find that, the outpatient protocols when it comes to alcohol detox. And now we're going to cover the inpatient. So inpatient is going to look like what, T?
All right. Really, there's two different scenarios. One is going to be what we commonly associate with. So our withdrawal management facilities, also known as detox and residential level of care. The other is going to be truly inpatient hospitalization at a big hospital. So those are really the two avenues that you will go down. most of the patients that we see are going to be referred to these withdrawal management, detox, and residential facilities. This is where they'll commit to going into an outpatient, or it's inpatient, but it's not a hospital, right? Facility where they have physicians, they have 24-hour, 7-day-a-week nursing. They have clinicians, case management, everyone on site. They run groups every day. They have in-house meetings. You have speakers that come in and run meetings and groups and things of that nature.
I want to bring something up real quick and just get through it real fast. I'm glad that you brought up the fact not a hospital, because I think it depends where you're at in the nation. Like, I'll get that call a lot of the times because we treat most of our clients are from out of state. And depending what state you're in, like Florida's a heavy treatment state. Like, there's a lot of recovery here. That it's just a big thing down here. Where our model's a little bit different. So a lot of people are familiar. When you say detox, they think hospital setting. Like, oh my God, you're going to send me to a hospital. And I always have to point out on the phone to the people that I'm recommending inpatient detox to, like, hey, we know places that this is what they do. They're standalone buildings that are 24/7 medical. Every staff member is there for the purpose of detox and detox alone. It's not, you're not thrown into a hospital that's a mishmash of everything.
Right.
Like, literally, these people specialize in this, and it's not like you're being thrown in a psych ward, so to speak. And I really have to make that clear to a lot of people. Like, trust us through this process. That's why I like referring to detoxes that I know, because Tom and I bring this up all the time, but we can literally walk into these detoxes and check on the people that we've referred there. Just check in on them, see how they're doing. They can meet us before transferring over to us, etc. But I just want to throw that out there, that people have this preconceived notion that it's all hospital setting.
Yeah, that's true.
I mean, a lot of the detoxes are the only thing they don't have going for them is it's boring. If you think about it, there's not, yes, there is groups and there is therapy and stuff like that, but the primary purpose behind an inpatient detox is to really just monitor you medically and get you through the really crappy times, because you're coming off of, massive amounts of alcohol or benzos. So
let me throw this out there real quick, just to like paint a little bit more of a picture. Like, for instance, the places that we work with, they don't put you in a hospital gown and make you walk around with your butt hanging out the whole time. Like, you literally wear your own comfy clothes, your hoodies. Like, it feels comfortable and accommodating.
Normal. Yeah.
Because obviously going through this process is as uncomfortable as it is. We try to make it as comfortable as possible.
Right.
Still hard, don't get me wrong.
So from your experience, what is going to be more of the criteria for an inpatient detox? And, if somebody's at home and they're doing a self-assessment of themselves, or a loved one maybe, what are some things that they could ask themselves or look out for?
I think most importantly is these inpatient settings are more of a timeout. They have to ask themselves, have you tried to stop drinking at home on your own? Has your family brought it to your attention that you cannot control your behavior while you're at home? Do you need to go somewhere and just take a complete time out from your routine, your habits, from driving by the liquor store, from getting liquor delivered to you, in your home? I think that's really important. And also, these patients, when you screen them, like, do you have a history of withdrawal seizures? Have you had DTs in the past? These are your really high risk patients. And or have you had any medical complications from either withdrawing in the past or from drinking in the past? Because a lot of times they're not going to the doctor and they have, medical issues going on. And then they get to our inpatient detox setting, that a lot of things come to light. Also, I would ask about their mental health. Are they suffering severe anxiety, insomnia, depression, irritability, mood changes? Is it affecting their work? Is it affecting the family dynamic? Is it affecting multiple aspects in their life? These are really the patients that you really want to push towards going inpatient detox, and also who don't have the support to do it at home.
What are some of the biggest medical implications of somebody that, drinking alcoholically for a long time? Like, what are some of the biggest, medical consequences, I suppose, is the best way to put it,
that we see?
Yeah.
Usually alcohol is directly toxic to your lining in your esophagus and your stomach. So a lot of patients get gastritis. Some patients get peptic ulcer disease, where you get an ulcer in your stomach or the first part of your small intestine.
That's called peptic
ulcer disease, where you just get this gnawing abdominal pain. You don't want to eat. You'll get really bad reflux, nausea, vomiting. And then that in turn can lead to like malnutrition. Very, very severe alcoholics, we will receive them and they'll have a BMI of like 17. They're supposed to be 6 foot, 200 pounds. They're 6 foot and 160 pounds because they're just drinking all day. They're not getting any type of nutrients.
That's how I was. I actually was, when I went into detox, I was about 180. And for me, that's not like, I'm 220 right now,
Yeah.
But I wasn't eating at all. And the only time that I would eat was after I had been drinking for at least, a couple of hours, because I didn't have an appetite. And then when I was eating, it was like hot cheese balls, whatever bar food garbage they had, chicken wings. I mean, it was really good stuff, but it was, yeah.
Yeah. So like malnutrition.
Since you brought up the gastro stuff, I just kind of want to point something out that maybe is like a fallacy out there. A lot of people, when I think alcoholic, like my brain goes to like the 50, 60-year-old, right? And I'm like, I think about the old man drinking or old woman drinking themselves to death. I want to throw it out there that we have had clients in their mid to late 20s,
oh yeah,
early 30s, pretty recently, that have had severe gastric issues to the point where they're like in the hospital regularly, even after getting sober. And I know some cases too that I've been in touch with for years who have stayed sober there's a couple of people I know that have multiple years at this point, constantly in the hospital to this day as a result of their drinking. And a lot of them are in their early 30s. And we know of somebody recently that just passed away at 32 years old. Alcohol only, no other drugs involved, body completely shut down. So I just want to throw it out there that, this isn't just the old man that's been drinking for 40, 50 years. This is literally happening to young people.
Yeah, and that person that you were referring to when you would see him sober, looked extremely healthy.
Yes.
You would not, he didn't have a distended stomach or anything like that. Wasn't, jaundice or any, looked like an athlete. And in 6 weeks, because I think he had probably 5 or 6 months of sobriety, relapsed, and in 6 weeks, dead.
He wanted to start his own personal training business and had the means to do so too. Like just to give an idea of how healthy he appeared on the outside.
We had a 24, 25-year-old that came in that was hospitalized for pancreatitis probably 5 times in 60 days. Pancreatitis, what is that exactly?
So you have your pancreas, which is here in the middle of your abdomen. It's directly related to it connects to your small intestine, and it secretes enzymes that break down fat. So when you eat fat, pancreas secretes, and then it helps digest fats. But when you get pancreatitis, alcohol is directly toxic to the pancreas. Essentially, the pancreas starts eating itself up because it's spilling its enzymes on itself, And that's why it's itis, so inflammation of itself.
Ew.
And you get severe, like I've seen people die from pancreatitis. So it can be on a spectrum of very mild to where it causes this severe inflammation in the body, and it can cause respiratory failure and death. So there's spectrums of pancreatitis. Recurrent pancreatitis can lead to chronic pancreatitis. And with chronic pancreatitis, the pancreas is also important for insulin secretion. So if you have chronic pancreatitis and your pancreas can't secrete insulin, you'll often see the older patients come in with type 2 diabetes because their pancreas is no longer secreting insulin, and now they're married to taking insulin for the rest of their life. But also the pancreas secretes enzymes that are important for like fat soluble vitamins. So vitamin A, D, E, K, right? And if you don't have your pancreas working, you get nutritional deficiencies too. So it's like all intertwined.
It's ugly. Nasty stuff, Ben.
But like you'll also see if someone's drinking very, very heavy, it doesn't matter how old they are, the person that turns yellow skin, yellow eyes, distended belly. It's called like you can get alcoholic hepatitis, where the alcohol directly affects your liver and the liver enzymes, and it can cause liver failure too. Like the mortality rate with acute alcoholic hepatitis is very, very high. And you often see these younger patients who don't understand like what's happening coming in with that. And they'll be stuck in the hospital for 2, 3, 4 weeks because their liver is failing them.
Now your liver, correct me if I'm wrong, but I mean, it's can repair itself rather quickly. Is that true?
It is the most healing organ in our body. Yes.
Wow. Oh, really?
But if you continue to do damage over and over and over again, that's what leads to cirrhosis.
Right.
And then with cirrhosis, you have, all of the other things that come along with that.
So in and of itself, I mean, alcohol is extremely, extremely dangerous. And, it's not something that to just take lightly. And the crazy thing is that there's no playbook, I suppose, or there's no specific amount. Like if you drink X amount of drinks, you're going to get pancreatitis, or you're going to get alcoholic hepatitis, or what's the one, esophageal
Varices?
Maybe. What is
the
that?
one where it burns?
No, that's esophagitis, which is just inflammation of the lining, which is similar to gastritis. But if you have liver cirrhosis, right, your liver is scarred, fibrosed, small, it becomes very hard like a rock. So I try to explain it to people. It's like you have tubes going through your liver. They're your blood vessels. Well, what happens like if you had a straw and you put a rock on a straw?
Yeah.
It impedes the blood flow. So then blood backs up, and it can cause hemorrhoids, right? But you also have those blood connections in other places of your body. So you can get those outpouchings in in your esophagus and in your stomach. And then some people vomit blood, they poop blood, like that. It's in a medical emergency. They have to go in and get them banded and taken care of.
Oh, wow. That doesn't sound fun.
No.
So the inpatient setting is going to, obviously, if somebody's undergoing detox and they have these medical issues, a lot of times these will get picked up on inside of a inpatient detox because they're drawing blood.
We draw blood, but you do like a standard panel. And usually what we're looking at are their liver enzymes to see where their liver enzymes levels are. Their bilirubin, that's what makes like your eyes level, your skin yellow. But we look at all of their thiamine, their folic acid, their vitamin D, so their nutrition. We also look at their kidney function, because if you're dehydrated and not eating, you can also get kidney issues. But we also look at their blood counts. Why? Because alcohol is directly toxic to your bone marrow. So when you drink, it suppresses your bone marrow from really functioning. So you'll see a lot of patients that get anemia or low blood counts. One, because they don't have the nutrition they need, but two, because alcohol, like they'll have a low white blood cell count, a low platelet count, and a low hemoglobin, because alcohol is suppressing their bone marrow from making cells.
I
I didn't know that. That makes me think, out of curiosity, I'll tell a little story with it. We had a client, this is when I was at another facility, just getting started in the field. I'd been working in the field maybe 2 years. And this gentleman came through our IOP program. He had gone through Detox, PHP, all that. Totally normal guy, normal conversation, intelligent. Came back about 6 months later. Had no idea who I was. Memory loss.
Yep.
Wet brain is what it ended up being. I've heard wet brain is when the alcohol saturates the spinal column and then it never comes out or something. I don't know.
Wet brain is more related to over time. It causes atrophy of your brain. So in certain areas of your brain. And those certain areas are related to memory, recall. It affects a certain part on the cerebellum, which is the smaller little part of your brain, which can affect how you walk. So sometimes you'll see, you call it like wobbly, like they walk with an abnormal gait. So that's over time, it can cause alcohol-induced dementia too, where patients just become demented because of the damage done to their brain. So some of those things can be related to nutritional deficiencies that if they're corrected, like in a timely manner, you don't get permanent changes. But the other ones are just alcohol over time, chronic, progressive, leads to these things. Also, it causes really bad neuropathy. Alcohol is directly toxic to our nerves and our like peripheral nervous system. So they get very painful feet, like the tingling, the numbness at nighttime, restless legs. You'll hear that a lot too. So it affects many parts of our body.
Yeah, that was one of the saddest things I ever saw. Like a completely normal guy. I think he was about 42, 43 years old. And then when he came back, it was like he was special needs. And you just knew his life was never going to be the same. He could never take care of himself again. Like cross that line.
Yeah.
Alcohol is like a slow torture to death.
Yeah.
You know, fentanyl, you're gone in an instant. Alcohol, you get sober, and if you drank enough, you could be living with these consequences for forever.
So the inpatient route in comparison to the outpatient, obviously, again, I refer you back to the previous episode where we cover the outpatient. There's a lot of things that you're getting inside of an inpatient setting that you're not getting at outpatient. So we'll cover those real quick, and then I think that'll wrap this up. But I think, and we'll just kind of rattle some off. The first one being the medical attention, I think is probably, I wouldn't say one's more important than the other, but I think the medical attention is very important. 24-hour nursing, doctor.
Every day they see a provider.
Yeah.
Every single day.
Blood pressure's getting checked.
They're doing
probably.
these CEWA assessments that we spoke about before. The nurses are doing that every day. So it's having those eyes on the patient for early intervention. You know, there are times where we have patients, you know, day 2, day 3, they're on their benzotapers and they're like, this patient's not doing well. Their blood pressure's sky high. They're confused. They've walked into other patients' rooms. You know, they're babbling off information. They think they're at home or they think they're at work. We really need to send them to the hospital for evaluation, like urgently, which you won't necessarily get at home because your family members aren't, if they're not medical personnel, how are they going to recognize something's acutely wrong like that?
Yeah, or they just aren't paying any attention to you.
Or they're by themselves.
Yeah.
And they don't know what to do.
Yeah. The therapeutic aspect of it, I mean, is minimal, but it's still there. Again, in the previous episode, we talked a lot about having some sort of support group, and part of a support group is, in fact, going to be a clinical component, if that's something that you can do. So you will be able to, a lot of them don't require, but most people do, because you're there, you may as well go to the groups, and they're not going to be anything crazy. Basic, generally speaking, groups around addiction, triggers, coping skills. A lot of the things that you would learn, in my instance, did learn. I didn't know anything about addiction. I just thought I was I like to drink, And when I was, in fact, in detox and residential, going into these groups, I started hearing things that I'm like, what? Really? Okay. And I started to resonate with some of this stuff. And that's good for somebody that is new at this. And if you're, a frequent flyer to detoxes, well, then maybe you just go there, camp out, and, eat your food and get you back up to fighting weight. What else are we missing?
You touched on the therapeutic side of it real quick.
Yeah.
I just want to throw it out there. It takes a very special therapist to work in the detox level of care. Because like you were just saying, so I have a close friend I was actually just discussing this with that works at a detox. And the therapists there essentially are there to talk you off a ledge. And pardon my French, because how many clients in detox get the fuckets? The anxiety kicks in and they just want to run out that front door. That's the other benefit to the inpatient side. Like, it really helps to have a therapist there, a professional that can, quote unquote, talk you off a ledge, so to speak. And this goes back to, we've talked about it numerous times on past episodes with like geographical change, for instance. When you're at home, it's really easy to say, screw this. Maybe you haven't even thrown out your liquor or anything. It's just sitting in your fridge. Where with the detox, there's at least some safety rails, some guards up that are going to slow you down. Like, if you make a decision to AMA, you got to go through the process of getting your keys from them, getting your wallet, your cell phone, like that kind of stuff. Like, it slows it down. And most of the time, a client will, through that process, be like, oh, I don't feel good enough to go through all this. I quit. Well, I'll just sit here, until they're better.
It's true. But also with that, then you have like the case management support. So they'll handle FMLA, the things, they'll do things for the patients that the patients wouldn't be able to do themselves, or know how to navigate. Like, how do I call HR to do FMLA, or what is FMLA? What is short-term disability? How do I ensure I get my benefits while I'm taking time off? But also, I think like the group rapport is big for them. I have patients all the time say like, I thought this was going to be the worst thing ever. And I'm pleasantly surprised that I've really met people who are like me and who are struggling with the things I'm going through. And it really helps me get through this process, because it's like they make a buddy system without even knowing they have a buddy system to get them through.
As family, too, it's important to remember sometimes not to get the cart ahead of the horse, where like, hey, just get them to detox. And exactly what you're talking about, Dr. T, their intention as the alcoholic is like, oh, I'm just going to do detox. But then their roommate's like, oh, I'm doing all levels of care. And they're like, oh, really? Where are you going?
Too.
Like, what does that look like? Oh, maybe I want to do that too. And that's where the importance of community comes in. And just taking it step by step. So as family, like, sometimes you have situations where just get them there. Get them in that first step, and we'll jump the hurdles as they come. Where other clients, you can just set the whole darn thing up and it just falls into place easy from the get-go.
Yeah.
And they do aftercare management too. Like, before I worked in treatment, I didn't know what PHP or IOP or any of that was. So they also educate them on like, what are these other levels of care? Why is this recommended? And then they help connect them with people to get them to aftercare.
Right.
Things that you can't really do in the primary care setting.
The other part that I want to mention too, and you touched on it, is the nutritional aspect of it. A lot of times when you're at home and if you're by yourself, especially if you're a bachelor or you're single or whatever the case is, like, you're probably going to, if you do eat, you're going to DoorDash or Uber Eats or whatever the case is. A lot of these inpatient detoxes, a lot of them have chefs and, cook really good stuff. And that's important. When you're first quitting drinking and you've been drinking for years on end or for however long and you're nutritionally bankrupt, you would be surprised at how quickly somebody will bounce back.
yeah.
I mean, your body, it's like, where has this nutrition been all my life,
Yeah.
Well, that's cool. That was fun. Ben, anything else?
I was just looking something up.
What are you looking up?
Since Dr. T's here, I want to know if this is accurate. This is out of the big book of Alcoholics Anonymous. Is there any science behind this? Page 134. I looked up where in the big book does it talk about chocolate. You should constantly have chocolate available for its quick energy value at times of fatigue. He added that occasionally in the night, a vague craving arose, which would be satisfied by candy. Many of us have noticed a tendency to eat sweets and have found this practice beneficial. Is there anything about sugar or something?
Well, because alcohol is all sugar, right? So you're basically just drinking sugar all day, right? When you're drinking alcohol, whether it's wine or hard liquor, that's all it is. So when you take that stimulus away, what does your brain crave? Sugar. People are addicted to sugar, whether you are in recovery or not, just the general layperson. So you often see that a lot of people whose substance of choice is alcohol, they want to have candy all the time, or they'll be like, I don't understand why I'm craving sugar all the time. And that's because also like that regulation in the body's off too.
That's my problem.
So Ben the alcoholic just said, I don't need detox. Just give me some pixie sticks. Right?
Yeah. That's why I can eat a whole box of Oreos 13 years later.
Yeah, I guess so.
Yeah. So I was really sugar. Anyways.
But briefly, the people who really need hospital, like not withdrawal management, freestanding facilities, like inpatient hospitalizations, are those patients who have heavy medical burden. So maybe someone who has COPD that's on oxygen, someone who has known cirrhosis that has to have like their bellies tapped frequently, congestive heart failure who have been in and out of the hospital for congestive heart failure, chronic kidney disease, things who are very high risk medically. Those are the patients that should be more referred to a true hospital for detox.
What do you mean by belly tapped?
So going back to cirrhosis, you have all this fluid that's backing up out of your liver. That fluid doesn't really have anywhere to go, right? So where does it go? Into their legs. Their legs get very swollen, and then into their belly. And their belly they look like they're like 9 months pregnant. And then we have to do a medical procedure called a paracentesis, where they stick a giant needle in your belly and suck out 4 or 5 liters of fluid.
Oh my God.
Mm-hmm.
That sounds horrifying.
Mm-hmm.
Does it hurt?
Generally, no, but obviously we pre-medicate. But they're awake. We can do it bedside in the hospital.
Oh, so it's like deflating a balloon almost.
Mm-hmm.
Oh, golly. That doesn't sound fun.
I'm like chuckling uncomfortably right now.
Yeah. That's like what's the procedure when you have to get for men?
Vasectomy?
No, I had that done. That was
okay.
nothing. Like
What?
if what do they call it?
Prostate exam?
No. To pee.
A catheter?
Catheter. Yeah. Yeah, never had that. Knock on wood.
Mm-hmm.
Hope to never need one.
I just broke out in a sweat.
I know.
Change subjects.
No, I think that was it. I think we covered just about everything. There's vast differences between a outpatient type setting and an inpatient type setting. I would classify it as you have your outpatient type setting that can be more for your professional that legit cannot get away from work. If that's something that you need to entertain for a period of time and give it a go, by all means, try. Then you have your inpatient type setting, which is going to be, what would you call it? Withdrawal management. Mm-hmm. And then obviously your hospital type setting where you're at that point, you're you just need to get sober because you're knocking on death's door. So, all right. Well, that was fun, guys.
Yes, it was.
Thank you for tuning in on the podcast app, whichever one that you choose to use. And thank you for watching on YouTube. In the end, if you have any comments, questions, or concerns, you can always reach us, info@realrecoverytalk.com. Again, that's info@realrecoverytalk.com. And ultimately, we want to help you turn your mess into your message. That is it. We will see y'all later.
Bye.
Do the wave, Tom. There we go.
I don't ever do the wave.